Welcome back to the Explainer class. I'm your professor today, and we are going to reverse engineer the incredibly delicate, high-stakes physiology of neonatal gas exchange. As practitioners managing the absolute most fragile lives in the NICU, our understanding of how oxygen gets in and how carbon dioxide gets out, well, it just can't be surface level. It has to be absolute. So we're going to break down exactly how these gases move, where they get stuck, and how we can use a mechanical ventilator not just as a piece of equipment, but as a precise extension of the baby's own physiology. Okay, let's jump right in.
To really understand our neonatal patients, we first have to respect the oxygen paradox. Oxygen is, of course, an absolutely life-saving molecule. It's the literal fuel for cellular respiration. But it is also highly toxic. In a developing premature infant, excessive oxygen drives severe oxidative stress. And this stress is directly linked to some truly devastating morbidities. We're talking retinopathy of prematurity, bronchopulmonary dysplasia, intraventricular hemorrhage, PVL, and even childhood leukemia. It's a molecule that gives life, but can just as easily threaten it. To put this into perspective, think back to the Great Oxidation Event billions of years ago. Early Earth actually had a weakly reducing atmosphere. When biologically produced oxygen first started accumulating, it literally caused a mass extinction. It fundamentally changed the Earth into an oxidizing, potentially lethal environment for early anaerobic life. Now, our cells eventually evolved to harness it, sure, but that underlying oxidative toxicity, it's still there, especially for a preterm infant whose antioxidant defenses just haven't fully matured yet.
All right, so here is our syllabus for today. First, we'll wrap up the oxygen paradox, then trace the journey of oxygen. Look at roadblocks in the NICU, dive into the mechanics of CO2, and finish up with clinical ventilation strategies.
Okay, Section 1, the oxygen paradox.
So, just to officially cement this idea of oxygen as a double-edged sword, before we get into the mechanics. Now, we all know association isn't strictly causation, right? But the immense mountain of clinical data linking oxidative stress to severe neonatal morbidities means we have to respect it. We simply cannot treat oxygen like a benign supplement. It's a potent drug. We've got to approach oxygen therapy with extreme caution, constantly walking that tightrope, balancing the need to prevent hypoxia against the very real, profound risks of hyperoxia.
Moving right along to Section 2, the journey of oxygen.
With that respect firmly in mind, let's look at the actual math of oxygenation. How does oxygen physically get from the delivery room deep into a premature baby's tissues? Well, the oxygen cascade is basically a massive drop in partial pressure. Think about it. We start at roughly 160 millimeters of mercury in room air. Once it's humidified in the airways, it drops to about 150. Down in the alveolus, mixing with CO2 brings it down to 100. And by the time it diffuses into the arterial blood, we're looking at just 75 to 100. This steep gradient is what naturally drives oxygen inward, but it really highlights how vulnerable the whole process is at every single step.
Now keep in mind that ventilation is intermittent, right? We take a breath, we pause, we exhale. But gas exchange at the alveolar level, that has to be continuous. So the newborn relies on functional residual capacity, or FRC, to make this happen. FRC is just the volume of air left in the lungs at the very end of a normal expiration. Think of it exactly like keeping a balloon slightly inflated. It keeps the alveoli from completely collapsing, it keeps that surface area open for continuous oxygen diffusion, and honestly, it makes it so much easier to blow the lungs back up on the very next breath.
And here is where it gets really fascinating. There is a direct relationship between that lung volume and blood flow. Pulmonary vascular resistance, basically the resistance blood faces when trying to pump through the lungs, is at its absolute lowest when the lungs rest exactly at FRC. If the lungs are collapsed from atelectasis, resistance shoots way up. If the lungs are overdistended, those tiny capillaries get crushed and resistance shoots up again. But right at FRC, blood flows effortlessly to pick up oxygen. This is the physiological sweet spot we are constantly chasing with our ventilators.
Okay, so the oxygen crosses into the blood. How does it travel? If we translate the oxygen transport cascade into simple math, it goes like this. The vast majority of oxygen is carried bound to hemoglobin. Every gram of fully saturated hemoglobin carries 1.34 milliliters of oxygen. Then, a tiny, almost negligible fraction is just dissolved in the plasma, which you calculate by multiplying the partial pressure of oxygen by 0.003. Add them together, and you get your total oxygen content. Why does this matter? Well, you could have a perfectly beautiful PO2, but if your patient is severely anemic, their actual oxygen delivery to the tissues is completely compromised.
And brilliantly, the body has this built-in mechanism to make sure oxygen gets dropped off exactly where it's needed most. It's called the Bohr effect. When arterial blood reaches metabolically active tissues that are actively producing CO2 and hydrogen ions, making their local environment slightly acidic, the hemoglobin literally changes its shape. It drops its affinity for oxygen and hands it right over to the tissues. It's this automatic, localized unloading system driven entirely by the waste products of the very cells crying out for oxygen. It's just incredible design.
Section 3. Roadblocks in the NICU.
So what happens when this elegant, finely tuned system completely breaks down? Let's look at the pathologies that block this journey and cause hypoxemia. We generally face a few major roadblocks. First, ventilation perfusion, or VQ mismatches, which we see all the time in respiratory distress syndrome and meconium aspiration. Then you have right-to-left shunting, where blood completely bypasses ventilated alveoli altogether. That could be intrapulmonary, like from severe atelectasis, or extrapulmonary, like in PPHN. And finally, we can face strict diffusion limits, where the physical distance between the alveolus and the capillary gets widened by something like pulmonary edema.
To really highlight how completely different diseases cause similar end-stage roadblocks, let's compare RDS and MAS. Respiratory distress syndrome is a disease of surfactant deficiency, right? It causes widespread alveolar collapse and atelectasis, meaning severely decreased ventilation. Meconium aspiration syndrome, on the other hand, creates intense airway resistance and this ball valve effect that leads to hyperinflation and air trapping. So they are basically mechanical opposites. One is way too little volume, one is way too much. But both of them ultimately destroy that FRC sweet spot we talked about, causing severe VQ mismatch and intrapulmonary right-to-left shunting.
All right, Section 4, the mechanics of CO2.
So oxygen delivery is highly complex and multifactorial. But now, we're going to shift gears completely and look at the exhaust pipe of the system, carbon dioxide elimination. CO2 transport is an entirely different beast. If you break down the numbers, a massive 85% of it travels through the bloodstream converted into carbonic acid as part of the bicarbonate buffer system. About 10% travels bound to hemoglobin as carbamate, and only roughly 5% is simply dissolved gas. Because it travels this way, the limiting factor for getting rid of CO2 usually isn't blood flow or hemoglobin levels. It is strictly, almost entirely about ventilation.
Another really fascinating aspect of CO2 is just how easily it moves. It diffuses incredibly quickly across biological membranes, and that includes the blood-brain barrier. In a mature brain, this CO2 acts as the primary, potent driver for respiration. When CO2 goes up, you automatically breathe faster and deeper. But here's the catch for us in the NICU. Our premature infants have an immature central nervous system. They have a dangerously diminished respiratory response to rising CO2. They simply won't increase their work of breathing enough to clear it on their own, which is exactly why we so frequently have to step in with mechanical support.
Okay, pop quiz time. Let's test your mechanical ventilation instincts. We know minute volume, which is what clears CO2, is your tidal volume multiplied by your respiratory rate. So if your neonate's CO2 is climbing and you need to eliminate more of it, which intervention has the significantly greater effect? Doubling the tidal volume on your vent or doubling the respiratory rate? Think about that for just a second.
Well, the math proves that doubling the tidal volume is far, far more effective. And here is exactly why. Anatomical dead space, which is the air in the trachea and tubing that doesn't actually participate in gas exchange, remains completely constant. Say your baseline tidal volume is 9 milliliters. About 3 milliliters of that might be dead space, leaving you with 6 milliliters of useful alveolar ventilation. If you double the rate, you just get more 6 milliliter breaths. But if you double the volume to 18 milliliters, that 3 milliliters of dead space stays exactly the same. So your functional alveolar ventilation jumps from 6 milliliters all the way to 15 milliliters. Your useful ventilation just skyrocketed by 150%. Crazy, right?
Managing this dynamic is absolutely critical, because dead space is relatively massive in neonates compared to their tiny tidal volumes. And we can easily worsen this dead space without even realizing it. We add external dead space all the time with endotracheal tubes, ventilator flow sensors, inline CO2 detectors, you name it. We can also create internal alveolar dead space through hyperinflation. If we push too much pressure and overdistend the lungs, we crush the capillaries. So now the alveolus is full of air, but there's literally no blood flow there to exchange gas with.
Which brings us to Section 5, Clinical Ventilation Strategies.
Let's apply all of this beautiful, complex physiology directly to the bedside. To manage CO2 effectively and maintain that perfect oxygenation sweet spot, we have to relentlessly reduce external dead space.
cut those ET tubes to the proper length, get rid of unnecessary adapters. We have to carefully recruit collapsed alveoli using PEEP to hit that FRC, while being hypervigilant not to over-distend them and ruin our pulmonary vascular resistance. We've got to optimize our respiratory rates and, critically, ensure adequate expiratory time, or T, so the baby doesn't trap gas and create internal dead space. Remember, every single setting on that ventilator is a profound physiological intervention.
Class, if you remember literally one thing from this explainer today, I want to leave you with the ultimate golden rule of neonatology. Oxygen is undeniably life-saving, yet it is deeply, deeply toxic. Its application must always, always be precise and judicious. We aren't just blindly turning a dial to make a monitor look good, we are actively balancing cellular survival against cellular toxicity every single minute of every single shift.
Which leaves us with a final thought to ponder. If oxygen is truly a double-edged sword, and CO2 elimination is essentially an exhaust system constantly fighting against the physics of dead space, how might deeply understanding this physiological knife edge change the way we design the next generation of life-saving neonatal ventilators? Could we say automate the search for that perfect FRC? Think about that as you head back to the wards. Thanks so much for joining me for this masterclass, and I'll catch you in the next explainer.